Welcome to this deep dive, everyone. Today, we have a very specific, really critical mission. We're taking a comprehensive, entirely clinical look at snakebite management.
Yeah, we are.
We've gathered the official medical and state guidelines to equip you with the exact step-by-step protocols for handling a snakebite. We are following the sequence of the official training slides, moving past the folklore, the movie tropes, and the chaos.
Exactly. No gossiping today.
Right. We're focusing purely on the science and the management portions, tracking the journey from the moment a bite happens out in the field all the way through, advanced hospital care.
And it's such a vital mission because while a snake bite sounds like, an exotic adventure gone wrong to some people,
Yeah.
for millions, it's a stark systemic medical reality. It's a severe occupational hazard that requires cool-headed, highly precise clinical action. No guesswork allowed.
Let's ground this in reality by looking at the sheer scale of the burden. We're going to use the state of West Bengal in India as our primary case study here. And the data is just staggering.
It really is.
In 2021 alone, there were 43,213 reported snakebite events in the state.
Sure.
And tragically, 354 fatalities.
Yeah, and this isn't just some isolated spike either. According to official data cited up through 2024, hundreds of deaths just continue to be reported annually. I mean, there were 297 deaths in 2022, 245 in 2023, and then it jumped to 485 in 2024.
Wow, that's a huge jump.
Yeah. And when we look at who is actually at risk, it paints a very specific demographic picture. It's primarily agricultural workers, plantation laborers, and crucially, children.
Right, and the reason children face a higher case fatality rate isn't because snakes, target them. It's just basic biology.
Yep, exactly.
If a snake injects the same amount of venom into a 40-pound child as it does a 200-pound farmer, the concentration of that venom in the child's system is just vastly higher, right?
Precisely. A smaller body volume means the venom reaches those critical lethal concentrations much faster. We see the highest incidences of these tragedies in areas with heavy agricultural activity like South 24 Parganas, North 24 Parganas, Midnapore, and various districts across North Bengal.
But there is a silver lining here, right? Like a serious commitment from the government to combat this.
Yes, there absolutely is.
Anti-snake venom, or ASV, is available year-round in all bedded health facilities. We're talking everywhere from major medical colleges all the way down to rural bedded primary health centers. Knowing that this system is in place and knowing how to navigate it is literally half the battle for you.
It is, but before we can navigate that medical system, we first need to understand the agents involved. In India, clinical management primarily focuses on what we call the big four venomous snakes.
Okay, let's identify the culprits. Who are the big four?
First up, we have the spectacled cobra, which is locally known as gokro or karish, and that delivers a neurotoxic venom.
Okay.
Then, the common crate or kalach. This one is highly deceptive and delivers a severely potent presynaptic neurotoxic venom.
Wait, presynaptic neurotoxic. So instead of just damaging the muscle, the venom is essentially it's cutting the telephone lines.
That's a great way to put it, yeah.
It's blocking the signals from the nerves to the muscles before they can even fire.
Exactly that. It paralyzes the communication system of the body entirely. Third is the Russell's viper, the Chandrabora. This snake is notorious for devastating hemotoxic effects, meaning it destroys blood vessels and clotting ability, and that's combined with mild neurotoxic properties too.
Nasty combination.
Very. And finally, there's the saw-scaled viper, or fursha, though it's relatively rare in the West Bengal region specifically.
But those are just the venomous ones. I mean, people share their environment with harmless neighbors all the time, and when they see a snake, they immediately just assume the worst, don't they?
Oh, all the time. You have the checkered keelback, or jaldora, which is just a super common harmless water snake, the Indian rat snake, or donruss, which is large and fast and often seen near houses.
Right.
People even panic over harmless lizards, mistaking them for venomous threats, like the Indian chameleon, the takshak, or the Bengal monitor lizard.
Which leads to a really dangerous human instinct. Someone gets bitten, and their first thought, or their family's first thought, is to find the snake, kill it, or catch it in a jar, and bring it to the hospital so the doctor knows exactly what bit them.
And this raises perhaps one of the most crucial myth-busting moments in modern medical guidelines. Visual identification of the snake is absolutely not essential for clinical management.
Really?
Really, do not try to capture or kill the snake.
The irony there is kind of painful. You have people trying to play detective when they desperately need to be playing patient.
G-Sax.
Wasting 20 minutes hunting out tall grass for snakes only delays the life-saving treatment they need at the hospital.
Furthermore, bringing a live, highly agitated venomous snake into a crowded emergency room, that creates a massive secondary hazard for the medical staff and all the other patients. It's strongly, strongly discouraged.
Okay, so message received. We leave the snake alone. Let's talk about the weapon itself, venom. What actually is it?
What's fascinating is just the sheer complexity of it. Venom is not a single simple poison. It's a highly complex biological mixture consisting of more than 90% proteins.
Wow, 90%.
Yeah. We are talking about over 100 different enzymes, non-enzymatic polypeptide toxins, and even non-toxic proteins like nerve growth factors.
And the delivery system is just as specialized, right? These snakes have modified salivary glands connected to long fangs, hollow fangs like hypodermic needles, in the case of the Russell's viper, or grooved fangs in cobras and cretes.
Right.
When they bite, they inject this chemical cocktail into the soft tissue, the fat, and the muscle.
And this leads to a critical physiological fact that basically dictates all of our first aid. The venom does not instantly enter the bloodstream.
Oh, it doesn't?
No, it is absorbed gradually, primarily through the lymphatic system. It's a slower transport network that eventually dumps into the systemic circulation later.
Okay, so think of the cardiovascular system like a high-speed bullet train. If venom gets in there, it's everywhere in seconds. But because the fangs inject into soft tissue, the venom has to travel via the lymphatic system, which is more like a slow, meandering drainage canal.
That's a perfect analogy.
And that slow canal is the only reason we have time to save the patient.
Exactly. And the amount it takes to be fatal is terrifyingly small. The fatal dose for a Russell's viper is about 42 milligrams. For a cobra, it's 15 milligrams.
Okay.
But the common crate, its venom is so potent that the fatal dose is approximately 1 single milligram.
Wait, 1 milligram? That's almost nothing.
It's tiny. Yet we have to circle back to our saving grace from the beginning of the show. Because of defensive striking or the snake simply running low on its venom reserves, about 50% of bites by these highly dangerous snakes result in zero venom being injected.
Right, the dry bites. But if venom is injected and is traveling through that slow drainage canal of the lymphatic system, we have to manage it immediately. This takes us to the clinical first aid protocols. The medical guidelines rely on a very specific acronym here.
Yes, the R.I.G.H.T approach. R.I.G.H.T.
Let's break down the physiology behind this. Step 1. R, reassure the victim. Now, this isn't just about good bedside manner to make them feel better, is it?
Not at all. It is a direct physiological intervention. When a patient panics, their heart rate spikes. Their circulatory and lymphatic systems work harder and faster. By panicking, they are literally pumping the venom faster toward their vital organs. You must keep them calm. Remind them that 70% of all snake bites, including those from non-venomous snakes, are completely harmless, and even venomous ones often dry bite.
Okay, so that's R. Then we have I immobilize the limb. The guidelines say to treat it exactly like a fractured bone. You use splints to keep the bitten limb completely still, and you keep it at heart level.
Correct. Muscle movement is what pumps the lymphatic fluid. If you walk on a bitten leg or wave a bitten arm around, you are mechanically squeezing that slow drainage canal and forcing the venom into your system.
So complete immobilization stops the pump.
Exactly.
Then we have G and H, go to hospital immediately. Don't go to a traditional healer. Every minute spent rubbing herbs on a bite is a minute closer to systemic failure.
Couldn't agree more. And finally, tell the doctor. The patient or family needs to report any symptoms that appeared during transport.
Like what kind of symptoms?
Are their eyelids drooping? Is their vision blurring? Are they having trouble breathing? Is the bite site bleeding continuously? These details are vital for the clinical team.
So that's the right approach.
Yeah.
But we also need to talk about the never do this list, because the folklore is incredibly strong here. The guidelines are explicit. No cutting the wound, no trying to suck out the venom, no herbal applications, no chemicals, and no ice.
Yeah, all of those are completely ineffective. They waste precious time and often cause severe secondary infections or tissue damage. But there is one folklore practice we really need to address with the utmost seriousness today.
The tourniquet.
Yes.
Tying a rope, a wire, or a belt as tightly as possible above the bite. The medical guidelines absolutely reject the use of tourniquets. Why are they so dangerous?
What's tragic here is that tourniquets often cause more amputations than the venom itself.
Wow.
When you tie off a limb completely, you cause ischemia. You starve the tissue of oxygen, leading to rapid gangrene. You can easily lose the limb, even if the snake didn't inject any venom at all.
And if it was a viper bite, it gets even worse. Right? Because you mentioned earlier that viper venom has a procoagulant effect, meaning instead of thinning the blood, the venom essentially turns the blood inside the veins into a solid gel.
Exactly. It causes massive inappropriate clotting. If you trap that procoagulant venom in the limb with a tight tourniquet, it causes microscopic blood clots throughout the distal blood vessels, completely choking off the tissue and severely worsening the local destruction.
That sounds horrific.
It is. But the most dangerous part of a tourniquet is the venom surge.
So it's like a dam breaking.
Yeah.
If someone ties a tight tourniquet in the field, the venom pools and builds up in the limb. If an untrained person suddenly unties it when they reach the hospital.
That massive, concentrated wave of venom floods into the systemic circulation all at once. It hits the heart and the nervous system like a freight train.
Oh my God.
It causes a catastrophic drop in blood pressure, severe hypotension, and rapid, overwhelming paralysis. Sudden removal can kill the patient instantly.
So paint the picture for us. A patient arrives at the emergency room with a tight, dirty rope tied around their calf. What does the doctor actually do?
The clinical protocol is highly orchestrated here. You do not touch that rope immediately. First, you establish intravenous access, you prepare your resuscitation drugs like atropine and neostigmine, and you get your airway equipment ready.
You have to be ready for the crash.
Exactly. Then you check for a distal pulse. Can you feel a heartbeat in the foot? If it's absent, you apply a standard blood pressure cuff above the tourniquet. You inflate the cuff, remove the rope, and then very, very slowly release the pressure in the cuff over several minutes, constantly monitoring the patient's vitals for any sign of shock.
It's a delicate, high-stakes procedure. So the patient is now in the bed.
Yeah.
The tourniquet is gone. The limb is immobilized. Now the doctor faces a massive hurdle. Diagnosis. They need to know if the patient was actually envenomated. But you can't just look at the bite marks, can you?
No, bite marks are highly unreliable. A common crate bite, for instance, uses needle-thin fangs. The bite is often entirely painless, usually happening while the victim is sleeping on the floor, and the marks can be literally invisible to the naked eye.
So relying on fang marks to judge severity is a dangerous game.
A very dangerous game.
So what are the actual clinical features the doctor is looking for?
Well, for local envenoming, particularly from cobras and vipers, the hallmark sign is painful progressive swelling, or PPS. The tissue around the bite becomes incredibly swollen, painful, and inflamed, and you can visibly watch that swelling advance up the limb over time.
But the true gold standard for diagnosing systemic envenomation, specifically the hemotoxic kind from vipers that destroys the blood's ability to clot normally, is a surprisingly simple test.
It is the absolute cornerstone of diagnosis. The 20-minute whole blood clotting test, or 20-WBC2.
I have to admit, I'm stuck on something here. We are in an era of million-dollar MRI machines and rapid computerized blood analyzers. But you're telling me the official state guideline for detecting a deadly viper bite is leaving blood in a plain glass tube on a desk for 20 minutes? How is that possible?
I know, it sounds archaic, but it is brilliantly effective. Because it's universally accessible, it's incredibly fast, and it directly answers the most critical physiological question at the bedside without waiting hours for a lab result.
Right.
Whether you are in a high-tech medical college or a rural primary health center at 2 a.m., you can perform this test accurately.
Walk us through the exact mechanism of this test.
Okay, so a doctor draws a few milliliters of fresh venous blood from the patient. They place this blood into a clean, dry glass test tube. They leave this tube completely undisturbed at room temperature for exactly 20 minutes. After 20 minutes, they gently tip the tube just once.
And the interpretation is entirely binary.
Exactly. If the blood has clotted into a solid mass, coagulation is normal. The body is functioning as it should. But if the blood remains liquid and runs down the side of the glass, the patient has abnormal clotting. The venom is actively destroying their coagulation factors.
And that means?
This means anti-snake venom, ASV, must be administered immediately.
But there is a massive caveat to this test. A detail that can cause a false positive and lead to giving antivenom to someone who doesn't actually need it. The tube has to be glass.
Yes, you must never use a plastic tube. And the reason is pure chemistry.
How so?
The surface of a clean glass tube has a negative electrical charge that actually acts as a catalyst to initiate the blood's natural clotting cascade. Plastic doesn't have that charge.
Oh, wow.
Yeah, if you use a plastic tube, the blood will stay liquid regardless of whether venom is present or not. You will falsely assume the venom is destroying the blood, and you will give unnecessary, potentially dangerous antivenom.
Which perfectly transitions us into the medical management itself and the administration of ASV.
Let's look at the algorithm. Let's say a patient comes in, there are no immediate signs of envenomation, no swelling, and their 20-minute blood test clots perfectly in the glass tube. Do you give them a little ASV just to be safe? Absolutely not. ASV is a potent biological product. It's essentially purified horse serum. It carries a real risk of severe allergic reactions, including fatal anaphylaxis. If there are no clinical signs, you do not give ASV.
But you don't just discharge them and send them home either?
No, you admit them for a mandatory 24-hour observation. Venom can have a delayed onset, especially with crate bites where neurological symptoms might not appear for hours.
Ah, right, the sneaky ones.
Exactly. So you keep them in bed and you repeat that 20-minute glass tube test every hour for the first 4 hours and then every 6 hours after that.
Okay, let's choose the scenario. The blood in the glass tube remains completely liquid. Or the patient is showing clear neurological signs, like their eyelids are drooping, a condition called ptosis. ASV is clearly indicated. What is the dose?
The initial dose is 10 vials, and this is a standard clinical guideline across the board for all patients, adults, and children alike.
Wait, 10 vials for a large adult farmer and 10 vials for a tiny child. That completely flips how I thought about body weight in medicine. Usually, a child gets a fraction of an adult dose.
It does seem counterintuitive until you look at the mechanism. The snake injects the same amount of venom regardless of the size of the victim.
Of course.
The ASV is designed to neutralize the venom load itself, not to treat the patient's body weight. Therefore, you need the same amount of antivenom to bind to the venom, whether that venom is inside a child or an adult.
That is fascinating. So you prepare the 10 vials, but it's not just the antivenom. There's a whole suite of supportive care that has to happen simultaneously.
Critical supportive care. First, oxygen is administered by mask.
Yeah.
Second, you start intravenous fluids using a fresh, normal saline drip with a brand new IV set. You never mix ASV into an already running drip that might contain other medications.
And because ASV is horse serum, it can trigger massive allergic reactions. How does the doctor handle it if the patient suddenly goes into anaphylactic shock while receiving the cure?
You stop the ASV immediately. You administer intravenous hydrocortisone and a strong antihistamine, adjusted for the patient's weight. You treat the allergic reaction aggressively until their vitals stabilize.
But once they stabilize from the allergic reaction, you still have the deadly snake venom circulating in their system.
Exactly. You are kind of caught between a rock and a hard place. Once they have recovered from the allergic reaction, you must restart the ASV, but you do it very, very slowly over 10 to 15 minutes, keeping the patient under microscopic observation to ensure they can tolerate it.
The guidelines also prescribe prophylactic antibiotics because a snake's mouth is full of bacteria and the puncture wound is highly prone to severe secondary infection.
Yes. Doctors will use a clinical combination, often an intravenous broad-spectrum antibiotic, alongside something to target anaerobic bacteria administered for several days to prevent the bite site from becoming necrotic due to infection.
So the doctor has neutralized the venom and they're fighting infection. But sometimes, depending on how long it took the patient to arrive, the damage is already done. This leads to severe complications. Specifically, viper venom is notoriously brutal on the kidneys.
It is. Russell's viper venom can cause profound acute kidney injury, or AKI.
And this isn't just the kidneys getting tired. The venom directly damages the microscopic tubules inside the kidneys and all those massive blood clotting issues we talked about earlier. They cause microthromby tiny clots that literally choke off the blood supply to the renal system. The kidney tissue starts to die and slow off.
Doctors look for clear clinical signs that this is happening. Oliguria, which is dangerously low urine output, or even anuria, where urine production stops entirely. Blood tests will show a dangerous spike in potassium levels and rising creatinine.
To combat this, the clinical guidelines detail a very specific intervention called forced alkaline diuresis, or FAD. Now, instead of reading the exact milliliter dosages from a textbook, let's talk about the concept of FAD. Think of the kidneys like a microscopic filter. Viper venom clogs that filter with dead tissue and blood clots. FAD is essentially a chemical power wash, right?
That's a great way to visualize it, yeah. It's a precise, multi-step pharmacological cycle designed to force the kidneys to flush the system before the tissue dies completely. First, doctors inject powerful loop diuretics to forcefully kickstart urine production.
Then they pump the patient full of specific IV fluids laced with sodium bicarbonate.
Right, the bicarbonate is crucial. It alkalinizes the system, changing the pH of the urine, which actually helps dissolve the damaging proteins and cast materials that are clogging the microscopic tubes.
Finally, they use osmotic diuretics, which forcefully pull fluid from the body into the kidneys to maintain a high-pressure urine flow. This entire chemical power wash cycle takes exactly 2.5 hours, with the clinical goal of achieving a steady, healthy flow of urine to save the renal function.
But if this trial fails, or if the patient's condition continues to deteriorate, the local medical facility has to recognize when it is out of its depth. The guidelines provide definitive referral criteria for when a patient must be transferred to a higher care hospital.
Let's look at when a doctor must make that call. For neurotoxic bites, cobras, and kraits, when do you refer them out?
You refer them out to a facility with a mechanical ventilator if you see progressive paralysis. Specific red flags include the patient's inability to lift their neck off the bed, their oxygen dropping dangerously low, or signs of bulbar palsy, which means they are pooling saliva in their mouth and have lost the ability to swallow.
That's terrifying.
It is. That patient is about to lose their airway entirely, and they need a machine to breathe for them.
And for the vasculotoxic envenomation, the vipers, when do they get referred for dialysis?
You step up to a higher facility if there is uncontrolled, continuous bleeding, even after administering maximum vials of ASV. You also refer if those signs of severe kidney failure are present despite the chemical power wash we discussed, or if the patient shows signs of fluid overload in their lungs. They need emergency dialysis to survive.
Now, beyond the immediate medical crisis of keeping the patient breathing and their blood flowing, there's a whole bureaucratic and legal reality to snake bites that doctors have to manage simultaneously.
Yes, the medico-legal aspect. By law, every unknown snake bite must be registered as a medico-legal case, or an MLC. Doctors are legally required to use the prescribed injury or poisoning report format.
And they have to involve law enforcement. Under Section 39 of the Criminal Procedure Code, a hospital must inform the police in the event of the patient's discharge, their transfer to another facility, or, tragically, their death.
And speaking of that worst-case scenario, the state guidelines highlight a very specific, critical bureaucratic rule regarding death certificates. It's a detail doctors absolutely cannot afford to miss.
What's the rule?
On the official death certificate for a snakebite victim, the attending doctor must not write the cause of death.
Wait, really?
Really, they are strictly instructed to write precisely this phrase. Exact cause is to be ascertained by post-mortem examination. The legal verification of a snakebite death must come from an autopsy.
And the reason for this strict protocol isn't just medical curiosity. It's about securing financial support for devastated families. These autopsy reports are the mandatory proof required for families to claim state ex gratia financial compensation for the loss of their primary breadwinner.
Exactly. The paperwork is as vital to the family's future as the anti-venom was to the patient's life.
It is a massive, complex system, stretching from the mud of a rice paddy to the intricate pharmacology of the ER, all the way to the legal paperwork of a hospital administration. Let's summarize the absolute essentials for you to take away from this deep dive. First, if a bite happens, remember the right approach. Reassure the victim to slow their heart rate, immobilize the limb like a fracture to stop the lymphatic pump, go to the hospital immediately, and tell the doctor your symptoms.
Second, do not try to catch the snake. Third, the 20-minute whole blood clotting test in a clean glass tube, never plastic, is king for diagnosing viper bites. And fourth, the initial dose for anti-snake venom is 10 vials for everyone, regardless of age or weight, because you are treating the venom load, not the body size.
Watch for those severe complications. Descending paralysis in neurotoxic bites, and uncontrolled bleeding or kidney failure in viper bites. And finally, document everything properly, because every bite is a medical legal case.
The precision required at every single step here is immense. But when the protocol is followed, when panic is replaced by procedure, lives are saved.
Thank you for joining us on this structured, clinical exploration of snakebite management.